Welcome everybody to the first working group meeting of 2022. I hope you all had a great holiday and that the new year is productive and healthy for everyone. I know it's not the most auspicious start to the new year with the way Omicron is going. And so that maybe gives us some motivation to think about these problems again and see what we can do about them. As usual, I need to remind you that this meeting is live streamed on YouTube and the recordings are made available after the fact. We only have one speaker today, which means we have a little bit more freedom for presentation and discussion. You know the drill. Reinhard and I are glad to see you here. You can always contact us if there are issues. Jim Sluka and Bruce are available also to help out. And we always appreciate your feedback. We have our various channels of social media. Really, as always, if we don't use them, they don't work. So assistance would be appreciated in distributing our existing archive of talks, which is very good, and in letting people know that there's a place to have discussions. We do have a Twitter feed if people would like to use it. Easy to remember, MSM Viral. And please do help us out with that as well. Are there any announcements before we get started on the seminars?
I wanted to ask something about SMB. Does someone know if SMB will take place as announced this year? Because the website says something like to be confirmed. Do you have any updates or?
I don't know. Reinhard, you're probably the person with the most SMB connection.
So I think at the moment that is the case. It's scheduled for early September in Heidelberg. So there are no plans as of yet, as far as I know, to either cancel that or change it to a virtual meeting. But of course, who knows? I just saw today that next month's AAAS meeting in Philadelphia, the in-person part was canceled and will become virtual. So who knows?
Okay, thanks.
I think American Physical Society is virtualizing their meeting for March as well. Any other announcements? No. Okay. So coming up, we have single talks booked for the next 3 weeks. Robert Hesser is going to talk about multiscale modeling of human physiology. Catherine Boscheman will be speaking to us. People are probably familiar with her work already. And then I guess the question mark means that there's still confirmation required on a talk with an intriguing title of "Is COVID vaccine likely to make things worse?" which sounds intriguing.
The question mark is, sorry, just to clarify, the question mark is actually part of the spelling of her name.
Ah,
she explains that on her website, but I know that's a little confusing, but I added that and I wanted to clarify that.
Okay, thank you. My apologies. I did not mean to.
Oh, that's all right.
Okay. And so that'll be an interesting talk. We definitely need suggestions for speakers. As always, feel free to suggest yourself, your students, your postdocs, people you would like to hear from. And don't be shy if you've already spoken. We can come together and have follow-ons on people's work. I believe we also have a steering group meeting tomorrow. Is that right, Reinhard?
That's correct.
Great. So those of you who need to be there know the reminder that we're having that meeting tomorrow. Okay, I don't want to take any more time from our speaker. Please do try to remember to mute microphones. Since we're going to have only one talk, you can ask questions after the talk, so we don't have to have a special discussion session separately. And we will jump right into quantifying the relationship between SARS-CoV-2 viral load and infectiousness, which is a critical missing piece of connecting the kinds of in-host modeling many of us do to epidemiological modeling. So please take it away.
So hello, everyone. So I'm Jeremie Guedj. I'm a researcher at the French Institute of Health. So basically, that's a national institution that is spread across many university hospitals. So the advantage of this type of structure is that we have access quite rapidly to clinical studies. And I just show you this first slide, which is basically how we have tried in our hospital to be rapidly involved in a research project at the very beginning of the COVID-19 pandemic. So the very beginning in France, that means end of January, early February 2020. So we worked mostly on three different studies that I will not present today that much. One, which is a cohort of hospitalized patients called French COVID. And you can see the first patient included very early February. The second large project is a clinical trial, which is still ongoing, which evaluates a variety of antiviral drugs in hospitalized patients. So that's virtually the same than what you have in the US with the active 3 studies. We are roughly evaluating the same drugs in the same population of patients with so far relatively disappointing results, but I will not discuss that today. And the third large project that we have been involved in is the development of a non-human primate model with here as well evaluation of variants of concern, with evaluation of drugs in this animal model. But here again, maybe something that somebody in our group could discuss for a subsequent talk. So basically, the idea that we have along this works is really how can we use the viral dynamics to understand different aspects of transmission, the determinants of transmission, and how can we use that as well to optimize the use of antiviral treatment. So I don't know exactly what is the audience of today, so I thought it was better to give some basics. As you may know, the viral load, I'm trying just to, yeah, like that probably to be better. Yeah, so the viral load looks like a bell curve after an infection. So it's starting from very small quantities, but as a result of the millions of virus that are produced by an infected cell, the viral load will rapidly increase after a couple of days after infection. You have this type of exponential increase of the virus. And the virus will peak between 5 to 10 days after the infection. And after this peak, the viral load will start to decline. So that's very similar in terms of shape with typical epidemic curves at the population levels. And that's, in fact, the models that are, the mathematical models that are used to model the viral dynamic curve within an individual are very much similar to the compartment model that are used in epidemiology. You can see that we have target cells, and these target cells are infected by the virus, and these target cells will move along that line, going from infected but not producing virus to a compartment where cells will actively produce new virus. So that's very similar to an SIR or an SEIR model. And we can, of course, use ordinary differential equations to model this type of dynamics. So basically what happens in that model, what is predicted is that the peak of viral load will more or less correspond to the depletion of target cells. So that's the time point where you don't have that much target cells. And after this peak of viral load, the viral load will start to decline. And it will decline more or less rapidly, depending on how fast the immune response, which is represented in this very basic model by the parameter delta, will drive how fast infected cells are eliminated. One of the issues that we have, obviously, is that the start or the initiation of this immune response, it's precisely contribute to clearing the virus, but it will also contribute to mechanism related to immunopathogenesis and uncontrolled inflammation. And if you look at the clinical, typical clinical evolution in patients, what you see is that the first symptoms are experienced roughly at the peak of our infection and in very first days after that peak. But it's only after 10 days that the risk of hospitalization and intensive care will occur. But that's not that doesn't correspond anymore to the peak of the viral load. That's several days after the peak of viral load have been passed, and it probably corresponds to a dysregulation of the immune response. So one thing that we have been largely interested in is, as I said, the initiation of antiviral treatment based on the experience that we have from previous viral infections and many works that Alan Perelson and others have done in the past 20 years. There is this idea that antiviral drugs have two main mechanisms of action. It doesn't mean that they don't have others, but the main mechanism of action that we expect from an antiviral drugs would be to block new cell infection or to block viral production from infected cells. And basically the idea is that during an acute viral infection, if you are able to initiate the antiviral treatment during the upslope of the viral kinetics, you might be able to break this increase, to reduce the viral load rapidly, and therefore to prevent this cascade of events that may lead eventually to hospitalization. Of course, if you start the treatment later on, then the effect on the clinical evolution might be much less dramatic. So the first type of works that we did was to characterize the viral dynamics in outpatients using the first patients that we could have during the epidemics. And that's how we came up with very basic, very crude estimate of the within host R0. Which we estimated to around 10, and exactly with the same type of interpretation that one can do for epidemiological models, we came up with first predictions that the target that we should take for an antiviral treatment in terms of pharmacodynamic target should be 1 minus 1 over R0. So roughly 90% should be the target, the pharmacodynamic target that one should have in order to make a substantial impact on the viral dynamics and on the disease progression. So actually that was already an important result, because just looking at the basic pharmacological properties of all drugs actually that were tested at the beginning of the epidemics, just using basic understanding of clinical pharmacology, it was obvious that these drugs would fail. They would fail because they were below this threshold of 90% just based on their PK/PD properties, and not to the fact that in many cases they were administered too late in the course of the viral load. Another aspect that is important in terms of viral dynamics, and I mean, I'm sure this is something that is obvious to many of you, but it's something that is still to me not sufficiently emphasized in many presentations, is the fact that when we analyze the data of the first patients that arrived in our hospital, it was obvious that the viral load was much higher in patients that were very early in their symptom onset, suggesting, and that's something that we confirmed later on by modeling, suggesting that the peak of viral infection in many patients coincided with the symptom onset. What that means is that it is roughly at the symptom onset that the patients have the highest viral load, which means that the contribution of pre-symptomatic individuals to the transmission was extremely important, and it's a key aspect of the difficulty to control the transmission of SARS-CoV-2. And that little by little pushed us to some aspects of our work that we did not consider that much until now, which was the relationship between the viral dynamics and the transmission. So viral load has been taken as a usual suspect, as a main driver of infectiousness since the beginning of the pandemics. I'm showing you here some papers that have been eventually published in 2021, but that were around as early as the first half of 2020. There is this Dutch study from Van Kampen. There is the English paper from Jones. This is our paper in PNAS, and both all showing the same results, namely that the infectivity as measured by the capability to culture the virus from an individual in vitro, the positivity of this viral culture was strongly associated with higher levels of viral load and being early in the time of symptom onset. So in both studies, you can see that the probability to culture the virus after 10 days post-symptom onset is extremely low. So it's really the combination of having a high viral load and being in the first 10 days of symptom onset that is probably key for viral culture, and which is used as a proxy of infectiousness. Another aspect that came up later on with the variants of concern was this idea that these variants had obviously a higher transmissibility than the historical variants. And it rapidly came in many studies, some observation that the viral load, either with the alpha virus or with the Brazilian, the gamma virus, or later on with the delta virus, were probably associated with higher levels of viral load. The problem is that there is this idea which intuitively makes sense that the viral load of with variants of concern should be higher, and that should explain the higher transmissibility. However, it's not so easy to demonstrate. The problem is that to demonstrate that properly, you need very frequent longitudinal data points to really evaluate the kinetics. And whereas most studies that we have in the literature are based on transversal and retrospective studies. So basically you have huge populations of patients, but you have only one data point per individual. You don't really know when this data point was sampled, I mean, in what time frame with respect to their symptom onset. So there is huge possibilities of bias that you may collect samples earlier or later in the disease. And therefore, it's very difficult to have a very solid understanding of how much these variants of concern differ in terms of viral load. One of the best study, albeit it's on a small number of patients, is this study by Rouyanke that comparing the English, the alpha and the non-alpha virus based on longitudinal and frequent measurements didn't find much of a difference between the two viruses. So showing that really this question is probably difficult to answer. Maybe there is a difference, but you need huge population to see it if it exists. And just relying on retrospective studies is probably not sufficient. But nonetheless, there is this idea that the viral load could be higher. The other thing, of course, that came up as an important question is the question of the vaccination. So how much vaccination is able to reduce viral load, and how much does that would translate in terms of reduced risk of transmission? The first studies that came up at the beginning of 2021 came from Israel, because they were leading this vaccination campaign. And the first studies that came up, that's the figure that you can see here. Basically what they did was to sample individuals that were vaccinated, but that had symptoms, and therefore had a PCR test done. So this is subject to bias, because you have the tendency to only diagnose and quantify viral load in individuals that are symptomatic, that may be just a small proportion of the overall breakthrough infection. And nonetheless, they found a tendency towards higher viral loads, so lower CT in individuals that were vaccinated. And they had this, they came up with this estimate that was later on published in Nature Medicine of about a 5-fold lower viral load in vaccinated individuals. Later, around June 2021, came up a much larger study in the New England Journal of Medicine, looking in a population of healthcare workers for which systematic PCR were done irrespective of the presence of symptoms. So therefore providing a much less biased estimate of real effect of the vaccine on breakthrough infection and on the viral load. And here they found a much larger effect of vaccination, where you can see that vaccinated individuals had on average a 1.5 log lower levels of viral load, so roughly 50-fold lower. They also found, an effect of the viral load, the time since vaccination and the viral load. But I mean, that doesn't really address our main question, which is to what extent viral load is really associated with the risk of transmission. And even now, I think that one of the best studies that try to address that question, in fact, coincidentally, is this study that was led in Catalonia at the beginning of the pandemic, so in March 2020. So this study didn't really aim to evaluate viral load as a driver of infectiousness. It was a study done for very rapid antiviral treatment. So the idea was very simple: identify individuals very rapidly, diagnose them, test, give them hydroxychloroquine with the idea that it could have an antiviral effect. But most interesting for us, you would follow these index cases, and you would ask the index cases to, you would also, follow the contact of these index individuals, diagnose the contact individuals, and follow them longitudinally. So basically, the design is very straightforward. It's a contact tracing study in which you make a longitudinal follow-up of the individuals. So you can see here the viral load in the index individual. So every index individual had 3 viral load samplings, and it was roughly decreasing, which is due to the fact that it's very early it's very difficult to have individuals before their symptom onset. So here you are already in the declining phase of the viral load. But what is more original is that you follow the high-risk contact. And what they showed in this study is that when you try to correlate the viral load at the time of diagnosis in the index cases with the attack rate, so how many individuals have been subsequently infected by this index, they found this tendency, albeit relatively low, that index cases with high viral load were associated with a larger proportion of contact that were subsequently infected. So that was one of the first evidence on a relatively large database that viral load in the index could be associated with an increased risk of transmission. So when we saw this data, we were immediately interested, and we contacted the others who nicely accepted to collaborate with us to try to see if we could do a slightly better job in characterizing this relationship. The idea was that, okay, the viral load at the time of diagnosis is not the viral load at the time of the contact. So you can use modeling to reconstruct the viral load, and you can use modeling to better assess what was the viral load at the time of the contact, and therefore have more statistical power to determine the relationship between the viral load and the risk of transmission after a high-risk contact. So the database was relatively large, as I'm showing you here, 259 index cases with available viral load. Overall, 582 high-risk contacts. 60% of the contacts were household contact and 40% were non-household. And the rate of transmission was 25% in household and 12% between non-household. So there was obviously a huge difference between a household and non-household contact. So this is just to have an idea of how the data look like. So the black circles here are the viral load in the index. Everything is with respect to the time of symptom onset. So most individuals, as you can see, are taken after the symptom onset, the viral load decline. And then you can put the time of high-risk contact. So you can see these 3 white squares tell you that these individuals had 3 high-risk contacts 5 days before he was diagnosed, but none of them led to an infection. In these individuals, it's different. He had 2 contacts, and both of them led to a subsequent infection. So we try to model this data so you have 2 things to model them. The first one is to reconstruct the kinetics, and that can be done with the type of simple models that I've explained earlier. It's difficult here to use more fancy models that involve immune response or things like that, just because the data, as you've seen, are very limited. But nonetheless, you can still use a standard target cell model. And then what is more interesting is to try to correlate that with the risk of transmission. And to do that, we used different types of models. But basically, the idea is to say that you have a probability of being infected, you have a probability that a high-risk contact leads to an infection, which depends on several factors. If the viral load is too low, so is below a certain threshold, the risk of infection is extremely small, and we set it up to 5%, and we tested different values, but it didn't change very much. So if the viral load is very low, is below the threshold, we know that corresponds to the threshold for viral culture. So it's very unlikely that this individual has enough virus to really leads to an infection. And then when the viral load is above 6, then you can test different functions that relate the viral load at the time of contact with the risk of infection. So here is an example. You have this model that tells you that the risk of infection increases linearly on the log scale for every increase of the viral load above 6 log 10 copies per milliliter. And how fast this risk of transmission increase depends also on the type of contact, whether it is in household or in non-household. So you have 2 different parameters. And it's of course also an individual specific. So each index for the same level of viral load, for the same type of contact, will have a different risk of transmission, just because every individual have some specificities in the type of contacts that they have, or more generally, there is a huge variability for a given level of viral load in the risk of transmission that is not captured by this model, that is not captured by the viral load. So you have this parameter, which is individual specific, but that nonetheless capture the association between the viral load and the risk of transmission. So as I said, we tested several models. I'm just focusing on 3 obvious models. The first one is a model where the viral load has no effect on the transmission. So what that means is that the risk of transmission at a given time t depends only on individual factors, such as the type of transmission, household or non-household, and the specificity of the individual, but regardless of any effect of the viral. And then you can test different functionalities, whether the relationship is log linear, logit, or is on the logit scale. So you can test different aspects. But what is the most important is that when you do the inference, when you try to estimate the parameters, you will estimate jointly, so simultaneously, the viral kinetics and the transmission events. So you are not fitting in 2 steps. You are really doing everything together, and you are trying to gather information from both the viral kinetics and the risk of the transmission event, your information to estimate your parameters. So basically, when you are using this type of model, one of the first predictions that you get is to reconstruct the viral kinetics. So that's how it looks like. You can see that the viral curve are not very fancy. It's this type of triangle or shape curve. You have the viral load that increase rapidly in individuals. They reach their peak roughly at the time of symptom onset, and then they decline. But what you can do now, you can really look at the viral load at the time of contact and how this is or not related with the probability of infection. So if we focus on the 3 models that I've described before, you can compare their parameter estimate in terms of longitudinal aspects. So that's the within host R0. You can see that we are still around 10 or 10-ish, as I said initially. You have this delta, which quantifies how fast the virus is eliminated from the nasal compartment. So this is very standard. What is more interesting is these parameters gamma 1 and gamma 2 that quantify how much viral load is associated with the risk of transmission, gamma 1 being in household contact and gamma 2 being in non-household contact. So what you can see immediately is that the risk of transmission is much higher in household contact than in non-household contact. So that confirms the fact that the risk of transmission is higher in household. But you can see also that the random effect, so how much this parameter may change from one individual to the other, the variability of this random effect is 85%. So what that means is that there is huge variability in that parameters. So that's clearly an indication that even if viral load is associated with the risk of transmission, it is only one aspect of the determinants of viral infection, and it's far from explaining all the risk associated with viral transmission. So as I said, viral load nonetheless is associated with transmission. You can see that in this model does slightly better than a model in terms of fitting criterion that would assume no effect of viral load on the risk of transmission with the same number of parameters. But the gain is nonetheless small. And as I said, most importantly, the individual variability is extremely large. So that's also reflected if you simulate the model to get a better understanding of it. If we focus on household contact, because that's where it's more interesting, if you simulate a large number of individuals according to that model, the black curve and the black interval here tells you the typical viral kinetic curve and the prediction interval in those individuals. So there is variability on the viral load, but it's nothing as compared to the variability in terms of risk of transmission. So this is the evolution of the risk of transmission. The dotted line here is the mean value. You can see that it's peaking exactly like the viral load, but with huge variations. What that means is that some individuals for the same level of viral load will be associated with a huge risk of transmission at their peak viral load, while some other will be associated with a much lower risk of transmission. Another aspect which is related to the model, but nicely captures some features that we know already from viral load, is that the risk of transmission decreases much more rapidly than the viral load. So that's very consistent with the idea that viral load individuals are probably infectious for a much shorter period of time as compared to the overall time of viral shedding. If we look at how the model fits the data against stratified and household or non-household contacts, you can see that it well recapitulates how the increase in viral load is associated with a higher risk of transmission. And you can see that for individuals that had a viral load higher than 10 logs per milliliter at the time of contact, the risk of transmission in household contact is close to 50%. And that's actually very close to the observed risk of transmission in this study population. In non-household contact, there is also a small effect of the viral load, but it's much less dramatic. You can also use the model to reconstruct some basic epidemiological aspect. You can, for instance, use this type of model to calculate the distribution of the generation time. So to do that, you need to assume some distribution for the time of distribution of contact. So we made two assumptions: either a time-varying distribution where the density of contact, the risk of, the probability of having a high-risk contact rapidly decrease 5 days after infection. That means after the symptom onset, just because you are symptomatic, you are isolating yourselves, and you have much less contact after that period of time. And another distribution, which is just uniform, so there's no change in the number of contacts that you have. And you can see that the model, especially when you assume a time-varying distribution of contact, well recapitulates this idea that the generation time is very close to 5 days. Obviously, if you don't make such assumption, then the distribution of the generation interval becomes much more flat, and it tends to lead to a higher generation time of 8 days. As I said, you can then, using this model, make a number of simulations, assuming, as we expect with variants of concern, that some parameters will be higher, for instance, the viral production rate. So if you assume that the viral production rate increased by a factor 2, by a factor 4, by a factor 6 or 8, as we suspect with variants of concern, you can see how that would translate in terms of viral load. The viral load would peak much more rapidly and to higher levels, but after some period of time, the difference would be relatively small. But because the viral load will peak more rapidly and because it will peak to a higher levels, the model would predict that it can make a huge difference in terms of transmission probability. And you can see here how the transmission probability can increase extremely rapidly because of this very rapid increase in viral load. Conversely, if you look at the effect of vaccine, and if you assume that individuals that have breakthrough infection will nonetheless have lower level of viral load, for the same reason that their viral production or the infection of new cells is hampered by the vaccine, then the effect on the transmission probability is here as well extremely important, and the transmission probability rapidly drops. So we have tried to summarize that with different typical scenarios. So if you focus on the fourfold increase of viral production, which was our estimate for alpha variants, you can see that the fourfold increase in viral production would lead to a huge effect on the mean rate of on the mean risk of transmission, with a 42% increase in the risk of transmission after an household high-risk contact. If vaccine is able to reduce the viral load dramatically by eightfold, which is kind of a very conservative estimate based on actually the alpha variant, you can see that the effect here as well on the transmission could be here as well extremely important. So again, these results are interesting, but it's obviously a story that continues to be written. And we have now, since the paper was done, we have now a number of observations that in some aspect challenge some of our assumptions. One of them, for instance, here is that the ratio between viral load and infectious virus, so how many infectious particles you have for a given number of viral particles, may be variant dependent. So that's here a study showing that individuals infected by Delta, for instance, have a higher proportion of infectious virus as compared to individuals that were infected by Alpha. So that means that for the same level in terms of copies of RNA, you have much higher number of infectious virus. You have also, similarly, this study that was done by Ruyan K and Alan, showing that the relationship between the infectiousness and the vaccination that this relationship between the RNA and the risk of positivity of infectiousness was also affected by vaccine. So for the same level of viral load, individuals that would be vaccinated would have much lower numbers of infectious particles and probably an effect on infectiousness. This, of course, was also prior to Delta and Omicron emergence. With Delta, we know that the effect of vaccine is probably much less dramatic than what we had with previous variants. This is a study by Kissler that showed that the effect on peak viral load, individuals that were vaccinated didn't differ much in terms of peak viral load. There was some difference in the time to viral clearance with a 2 days difference, but not so much on the peak viral load. And you have also this study that just came up today that I wanted to mention, which looked at the effect of vaccine on the risk of transmission. And you can see that at least with back to the time of the alpha variant, the effect of vaccine was dramatic on the risk of infection, with almost a 70% decrease in terms of transmission with alpha. But this risk became much bigger with Delta, and the effect of vaccine on the risk of transmission became much less dramatic. So it's obviously something that need to be updated with the new information that we have now. So for those who want more information, the paper is published in eLife. And yeah, I would like to thank all the collaborators that contributed to these studies. And we have postdoc position open, so if any students is interested, please contact me. Thank you.
Fantastic. So the floor is open for questions.
I have a quick question. Oh, sorry. Please go ahead.
Thank you. So the variability that you explained, first, very nice talk. I really enjoyed it. Thank you for that. The variability in some of your Delta factors may also come from the fact that it's known that as this virus is transmitted through respiratory droplets and aerosol, that there is a huge variability in the number of droplets an individual produce when they talk, even doing exactly the same activities. Is there a way, or do you, that you could implement that in your model? Try to look at the effect of how many droplets are exhaled, which would be basically a number of how many potential viral particles are exhaled.
So it's definitely something that is critical. It's not possible to study that in this clinical study because that's only retrospective. One thing that we could do would be to access the list of symptoms in individuals, at least to see whether transmission was associated with individuals that had, more intense coughing or something like that. But the problem is that in any case, you will have the symptom after the individuals have been enrolled in the study and not necessarily the symptoms that they had back to the time of their high-risk contact. So I'm not sure that you can really do anything with this study, but that's something I think that have been already evaluated, for instance, in animal studies. I've seen studies in, I don't know if it's in ferret or in hamsters, where they measured the number of infectious particles in the air and how much that was associated with transmission. So that's in human studies, I'm not sure that anything has been done.
It may also be that the contact, it would be interested, I know it's retrospective and you don't have that information, but what kind of activities they were doing when they were in close contact with somebody that was infected. Because if they were just sitting outside, looking at the sunset, or if they were running in a gym, that may affect.
No, you're absolutely right. And there is even more basic information that we don't have here, which is that high-risk contact was defined as individuals that didn't wear a mask, but individuals could wear a mask part of the time, especially because a lot of these contacts were through hospitals, between healthcare workers or between healthcare workers and patients. So there could be some part of the time where individuals were masked. There could be also part of the time where the contacts were masked, and that was not informed in the study. So that's definitely a huge limitation of this type of retrospective analysis.
Thank you.
I had a quick question about when you had to decide on the time of interaction between the index cases and the contacts, and you seem to be taking a specific time point. I would imagine that, for example, if it's a household member, it would be interaction over several days, and similarly for people at work, etc. So I wonder, how do you decide on a specific time point, or do you take a range of possible dates of interaction?
Yeah, so that's a very good question. So first of all, we did not decide of the time of contact. That's what was informed in the database and in the clinical study that was originally published. We also had the same question actually for the investigators. What they said is that it might be that in some cases, the time point that is informed in the study as the time of contact between household contact it could be that in some cases there were repeated contact. But they said that in many cases, it was not the case, just because people were aware of the pandemic starting. It was in March 2020. So people back to the time were really worried about SARS-CoV-2. So they said that it's possible that what they used as a single contact would actually encompass several contacts. But they said that in the majority of the case, they expect that that was a reliable information. But you're right, again, we go again to the limitation of this type of study that was not designed for that purpose.
Yeah, I can just mention that our experience from such investigations in Israel is this data is very poor. Like they would usually take like the last time of interaction, but you live with somebody for several days. So it might be the day before that or 2 days before that, and similarly with work. So anyway, it's an inherent problem with the data, I guess.
Yeah, but it's something nonetheless. Maybe we could try to do some analysis just to consider that they have several contacts during the days before, whether that change our estimate of the parameters. That's something that we could try. To what extent this is sensitive to assumptions on the time of contact.
Because almost all of your contact points were early, right? They were all before you had the data set, because presumably once you started taking the viral loads, they were hospitalized and they weren't contacting.
Not necessarily hospitalized, but yeah, they were.
But at least we're under surveillance.
Yes, yes, absolutely.
If I may, just one more, it's kind of a question to you, but also I can't resist the temptation of putting it to the larger audience because of the crucial importance. Do you have any speculations about Omicron and the generation interval, either by you or somebody else here, because it's such an important point right now?
Well, I think that people were saying that the generation time was probably now as short as 2 to 3 days, no?
It's being claimed based on, as far as I could tell, pretty little information. So if anybody has more input,
no,
I think
there is this Norwegian study, you know, this Norwegian, they had the party and they looked at how fast people started to, but it was more the incubation period. Yeah, regarding the generation time. No, I don't know if anybody has a better estimate.
Is the symptom onset also still, 4 or 5 days, or is the symptom onset also more supposed to be more rapid?
Yeah, the symptom onset is supposed to be more rapid, but it's also that the symptom onset, some people claim, I don't know, I'm not a virologist, but they also say that symptom onset might be earlier, not necessarily because the viral load is higher, but also because most individuals are vaccinated. So you could have symptoms just because the immune response starts to kick in more rapidly and doesn't wait until it's peak of viral load. But I don't know if anybody has better data.
So I had a question about a paper of yours, which I think is earlier than the work that you presented here. It's called Modeling SARS-CoV-2 Viral Kinetics in Association with Mortality in Hospitalized Patients from the French COVID cohort. So it's from August 2020, so it's a bit earlier paper. But since I had read that, I had a couple questions. One was whether so there seemed to be quite a lot of loss to follow up in that paper, and I was wondering whether even when the patients were censored, you would be able to know whether there was mortality. Like sometimes with loss to follow up, you don't have all the information, but you still can track mortality or not. And the second question was, you talked about in that paper about various factors that seem to be have an effect, including male gender and chronic pulmonary disease. And I was wondering if you had smoking status, and if given and related to that, like given one of these factors, like could you take conditional dependence relationships? Like if you know that somebody has chronic pulmonary disease, is their being of the male gender no longer informative? Or if you know that somebody is a smoker, then is their being over 65 no longer informative? Something like that.
So the first question regarding mortality after discharge, we had this information because it was a cohort. Patients were supposed to come back to subsequent visits. So yes, we have this information, and I think, it might be that in some individuals, I don't have the exact numbers in mind. It might be that we didn't have that for every of the 650 patients, but I think that, I'm sure that for the vast majority of them, we had this information. For the smoking status, I'm sure we had that also, but remember that most individuals that are hospitalized, they are relatively old, so they might be former smokers, and that doesn't mean that they have active smoking. So that's, if I recollect correctly from that time, I think that's the interpretation that we had. Actually, in some of these previous analysis, I don't know if it's on the final database of this cohort, you could even find sometimes a protective effect of smoking just because the individuals were younger, So it's just difficult to interpret the smoking status in this population of old patients. Now, whether your last question was about defining a score, right, based on the
well, it was, so you had said the effects of various single variables, and I was just wondering if I mean, it's more like the importance of various variables. Like if you knew that, so you could have a conditional independence relationship that given that the person is male, then the fact that they're over 65 matters less, or something like that.
Yeah, so that's basically something that you can test with interactions.
Right.
Test with whether these covariates are yeah. Honestly, I don't remember if we tested that. I'm sure that many people have done this type of analysis because, you know, the baseline clinical factors associated with mortality, I think this is something that has been largely studied. I don't think that we tested much the interactions. I think we did a standard survival analysis to define the most critical clinical factors at baseline that were associated to mortality, and we adjusted on these factors to test whether viral dynamics after hospitalization was an independent predictor of mortality in this population.
Okay, thank you.
There was a question in the chat from Slim. At the beginning of your talk, you suggest that antivirals need to be given in the first 10 days of infection and kill 90% of virus to be efficacious. Do you know if Paxlovid from Pfizer reaches those levels, and is it predicted to work based on your SIR model? I thought it needed to be given within 48 hours of disease onset.
So basically, initially, what we said with Alan, and that was very basic predictions, that the earlier the better. Now, what we learned over the time is that even in hospitalized patients, some of them will have high levels of viral load, and in those individuals, there is a benefit of giving an antiviral treatment. And this is to some extent confirmed, for instance, by the recovery study. So that's the large English study that showed that monoclonal antibodies in this population reduced mortality by 30%. And that's especially true in the population of individuals that are seronegative at hospitalization. So individuals that presumably have higher levels of viral load. In the PNAS paper that was mentioned just before, it was the same thing. Some individuals arrive at the hospital and they have very low level of viral load, and presumably in those individuals, antivirals will not make much of a difference. But there are a significant portion of individuals in whom viral load is still very high and could benefit from an antiviral treatment. So for Paxlovid, I don't know. For monoclonal antibodies, I would say that the data that I've seen with different monoclonal, whether it's Regeneron, AstraZeneca, and so on, you are most likely above this 90% threshold. Yes.
There's a comment from William, says, talking about the distinction between generation time and doubling time. A 2.4 day doubling time in a reproduction number 4 yields a generation interval of about 5.5 days with standard deviation of 1.8 days. And so I think this is in response to the question about Omicron. I don't know if you want to maybe talk a little bit more about the difference between doubling time and generation time.
Yeah, that's not really my, yeah. Yeah, no, that's not really the numbers that I know. Yeah, I don't know exactly how to translate them. Again, what I can say here is that, yeah, the generation interval that we could calculate based on the within host models, but I agree, it needs to be compared with epidemiological models. But what is reassuring for us is to see that what we have at the within host level is coherent with what can be done at the epidemiological levels, just looking at the chains of transmission.
Very good. Time maybe for one last question before we break. No. Well, thank you everybody for coming again. Welcome to the new year. Thank you so much for the wonderful talk. And we appreciate you staying up late in Paris for us.
Thank you very much for the invite. Very
I
happy.
I hope we'll have a chance to see you in person before too many more years have passed.
Likewise.
Okay, thank you, everyone.
Thank you very much. Bye.
Bye.